Hi guys, welcome to Fast Coder 21 Medical Coding YouTube channel. The purpose of the channel is to help the people who are in need of medical coding reliable resources. If you are already subscribed to our channel, help your friends to subscribe. If you are visiting for the first time, then click on the subscribe button to receive future updates in the medical coding field. This channel is helpful for freshers, experienced coders, aspirants of AAPC certification exams and AHIMA certification exam. If you have any other topics or concerns, please mention in the comment section. Please click on like button to encourage and motivate us. Please watch until the end to gain in-depth knowledge about ICD-10-CM, CPT, ECPIX coding systems, as these Q&A sessions are very useful in live coding, medical coding interviews, CPA, CPC and CCS certification process. Guys, if you go to any interview or any certification exam, keep familiar with the code books like ICD-10-CM, CPT, ECPIX, as our sessions will assist you in the process of interviews or certification exams, but not an alternative to both interview process and certification exams. So today our topic is Evaluation and Management Coding Using Time 2021. So determining the level of E&M service. Basically, we will use two approaches for level to find the E&M service level. So one is using medical decision making and second one is based on the time. So in this session we are going to learn how to level the E&M coding using the time. So here consider assigning E&M level based on time. So when do we use time basically? So when do we use time for leveling the E&M coding? So here focus the visit on only one chronic illness diagnosis without severe exacerbation, progression or side effects from treatment. Spent a considerable amount of time collecting the history or performing the exam, ordered several tests, reviewed complex data and spoke to the physician. So we need to check document to find out these keywords here, like focus the visit only on whether physician is checking only chronic illness, only one chronic illness, and we need to check whether it has any exacerbation, progression or side effects from treatment. So if the patient has severe exacerbation, progression, we will not use time based coding, then we will use MDM coding, like using the medical decision making here. So here we need to find the keywords to know whether we can code using the time or not. If the patient has chronic illness without any exacerbation or progression, we can code based on the time. Definition of time for office outpatient E&M. The definitions and rules of time differ depending on the category for E&M coding. Hence, we must be aware of these differences to ensure proper documentation and coding. As you know, we have whenever we code E&M using the time, we have new patient and established patient. So in every specialty we have 4 levels. Like based on the level, time differs. So we need to know the definitions before assigning the time based E&M coding. Here see, if you see this table we can understand easily. Outpatient E&M coding, visit level, this one is new patient code, this one is new patient time, this one is established patient code, this is established patient time. So level 1, see here new patient has more time, established patient has less time. Do you know why? So basically if the patient is new patient, the office staff or reception department or physician needs to spend more time with the patient, new patient. That's why here the time is high. So if it is established patient, these activities will take less time. So here the time is very less. Like 10 minutes differ. Here 29, here 19. So 10 minutes decreased based on the established patient criteria. If it is a new patient, more time. If it is an established patient, less time. And please note all these times are mentioned in the minutes, like 15 to 29 minutes, 30 to 44 minutes, 45 to 59 minutes, 60 to 74 minutes here, 10 to 19, 20 to 29, 30 to 39, 40 to 54. These all comes in the minutes only. So total time combines the time provider spends on the face-to-face visit and non-face-to-face encounter on the encounter date. So here we need to consider both face-to-face as well as non-face-to-face encounter on the encounter date with the patient. So various tasks like reviewing tests before the patient are present or coordinating care after the patient leaves, the time required for the visit may be included while calculating the total time. So these all are included in the total time. Anyway, don't worry, we have point wise in the down, so we can learn easily. Moreover, there is a revision in total visit time for 2020-21 to include both face-to-face and non-face-to-face time personally spent by the physician as well as the other healthcare professional on the date of the encounter. So here the meaning is, so here both face-to-face and non-face-to-face, whose specialties we can take this time. So we can consider physician as well as the other healthcare professionals. If those people performs the visit, we can count the time. If we check here, qualified healthcare provider QHP time spent by QHPs counts toward total time for an E&M visit. So if the patient is seen by QHB, qualified healthcare provider, we can take those time to count E&M coding based on time. So AMA definition of qualified healthcare provider. A qualified healthcare provider is an individual who is qualified by education, training, license, regulation and facility privileging, who performs a professional service within his or scope of practice and independently reports that professional service. So this is the AMA guideline. So we need to remember who is a qualified healthcare professional. So okay na? Okay, here who are considered as qualified healthcare professional here. So nurse practitioners, physician assistants and certified nurse specialists. So if these three categories perform the encounter, we can code time and we can consider their time when we are coding the E&M coding using the time. So here the most important point to remember here is total time does not include the time spent on activities normally performed by clinical staff. So here you need to remember that based on the definition of AMA, so we can take the timings of qualified healthcare professionals, but we can't count like service by the clinical staff. Here you may get the doubt, who are the clinical staff? We can check here. So medical assistants, licensed practical nurses, registered nurses. So if these three categories performs the service or encounter day, so we can't count their time in the while coding the E&M coding based on the time. So basically here the thing is that if the QHP performs the encounter, and we can count their time for counting the time for E&M coding. If the clinical staff perform the encounter, we can't count their timing while coding the E&M coding using the time. So here we will learn how do we count split or shared visits. See here, when the physician and a qualified healthcare professional performs the E&M, the time spent by each is summed for the total time. So for example, physician will spend 30 minutes, physician assistant will spend 30 minutes and a physician spends 15 minutes. So here we need to add both 30 and 15. So here counts like 45 minutes. Here what is the keyword here? Here it is a, see here we have the keyword established patient. So we need to code from the established patient category of timings. So here it counts totally 45 minutes including QHP as well as the physician. VA means physician assistant spends 30 minutes and physician spends 15 minutes. Total it is 45 minutes. If we check our timings, our timing is 45 minutes. So here this level is 99215 level 5. So here we have combined the timing of physician as well as the qualified healthcare professional. As the AMA meaning, we can count QHP's timing while coding the E&M coding using the time. See here, as it is established patient and total time is 45 minutes including 30 plus 15, so it supports level 5. Here we have like trips. Here is the list of activities counted toward a physician's total time or QHP. While as you know, we can count QHP's time also while coding the E&M using time. See, here are the list of activities counted towards a physician total time. These are the activities which are included in the physician time. So, if the physician performs all these activities, we can count it as a, we will include all these things in the like while coding the E&M coding using the time. So we need to check the documentation to find out whether physician is performing all these activities or not. So here first one, preparing to see the patient. Example, review of tests. Performing a medically appropriate examination under evaluation. Ordering medication, test or procedure. Obtaining and or reviewing separately obtained history. Documenting clinical information in the health record. Referring and communicating with other healthcare professionals when not separately reported. Independently interpreting results and communicating results to the patient, family, caregiver. Counseling and educating a patient, family, caregiver. Care coordination, not separately reported. So all these activities are self-explanatory. You can understand easily. You need to do only one thing, very important. You need to find these keywords are available in the document or not. If you have all these keywords, you can count towards physician total time. If you can't see these keywords, you can't code those total time. Here we have a other list, activities that do not count towards total time. Time spent on a calendar day other than day the patient was seen. Services that are separately reportable. For example, you see here interpretation of tests that have separate CPT codes. Transitional care management reported with 99495 and 99496. Chronic care management reported with 478, 490, 489. Clinical staff time, activities performed by medical assistant, licensed practitioner, registered nurse. So we can't code clinical staff time, chronic care management, transitional care management, interpretation of tests. So these are not included in while coding the E&M using the time. So for longer visits, there is a prolonged visit code 99417 that should be reported with 99205, 99215 for every 15 minutes. The total time exceeds the ranges for those codes. CMS, however, has decided to allow physicians and other healthcare professionals to bill for prolonged services only when they have exceeded the maximum time for a level 5 visit by 15 minutes or more. At least 69 minutes for an established patient and 89 minutes for a new patient rather than minimum time. Because of the discrepancy, Medicare has its own code G2212 for reporting prolonged services. So basically here we will use 99417 prolonged visit code is along with 99205 and 99215. We can't use 994175 with other codes. You need to use only these codes 99205 and 99215. So here the meaning of 69 and 89 is 69 minutes is for established patient. For example, if you take 99215, for 99215 level, we need to check 40 to 54 minutes. So here 54 is minimum. If we add 54 plus 15 minutes interval, so 54 plus 15, 89. If it is 89 minutes, we can code prolonged visit code 99417. If it is 88 minutes, we can't code 99417. It is included in the 99215 only. Anyway, we can see few example going down. Okay. So after knowing the role of the time component in E&M services, we must know how to eliminate confusion surrounding time-based coding. Here are some tips for coding based on time and an office visit example. Example, a 86-year-old established patient with mild to moderate dementia who lives in an assisted living facility represents with confusion related to her medication regimen. She also has diabetes and hypertension. Pill counts are performed during the visit and records from an urgent care center reviewed. The physician also reviews medication pickup history with the pharmacist. In addition to periodic urgent care visits with medication changes, the physician discovers erratic refill patterns. So, she is not using medications properly. Erratic means there is a disturbance. So, sometimes she is taking, sometimes she is not taking. So, the physician has a phone call with the patient's family member who has power of attorney and helps with pill planner. Pill planner means they will inform to the power of attorney how to use the pill. They discuss medication adjustments and a plan to shift the patient's medication administration to supervisor. So, always POA has to supervise patient's medication. So, here is the time for each activity could break down and how the physician or PHP could track it. As you know, physician we can count time using the physician as well as the PHP. PHP means qualified healthcare professional as we read previously. So here activity, pre-visit planning, chat review and face-to-face encounter. So 18 minutes which is tracked by EHR. So EHR means electronic health record. So in the above example, physician reviewed the urgent care records also. So here also is physician spent to review urgent care records 6 minutes. Discussion of medications with primary pharmacy technician 11 minutes. Phone call with family members like POA power of attorney 13 minutes. Coordination with office staff for medication adjustment and bubble packing 5 minutes. Final documentation of visit 4 minutes. Like tracked by EHR. Final last and final activities counted by EHR here. So here if you count 18, 6, 11, 13, 5, 4, it will count 52 minutes. So as she is an established patient, 52 minutes means it goes to level 5 like 99215. So whenever you are going to count using the time while coding E&M, you need to check the points like this way. You need to check the activity, each and activity based on this one, so that you can easily adjust the time and code properly. So prior to 2021, only the face-to-face time with the patient can be considered for time-based coding. So before 2021, we need to consider only face-to-face time of physician with the patient. But after 2021, but we can code using the non-face-to-face visit also. So here we have one more example. A 68-year-old woman with a history of abdominal pain and diarrhea and diagnosis of IBS means irritable bowel syndrome comes to see the physician after seeing 2 other GIs means gastrointestinal specialist and sends her records in advance. She is coming to see the physician for a second opinion with waxing and waning chronic symptoms. Here, physician spent 25 minutes the day of her visit reviewing her records, including previous chats and labs, 20 minutes talking with her about her history, and face-to-face counseling and 25 minutes in chatting. After she leaves for total of 70 minutes spent. So here the code is 99205. As she is a new patient, we need to code 99205 series. So if you see our chart, as she is a new patient to this physician, so 60 to 74 minutes, in between 60 to 74 minutes, we need to code, our time is 70 minutes, so we need to code 99205. So I hope you got understand this. So a second example, a PCP refers a patient with a complaint of chronic worsening heartburn to physician with no significant records. Physician spent 30 minutes total time including discussing with the patient, ordering test and charging. Here time is equal level 2. As it is 30 minutes, she is also a one more example we have here. A PCP refers a patient with suspected IBD with records. Physician assistant spends 40 minutes of the shared visit with the patient taking history and symptoms. Physician spends 30 minutes of total time reviewing the records, talking with the patient, ordering tests and charting. Here the total time of the visit includes PS time 40 minutes plus physician time 30 minutes for a total of 70 minutes, so which leads to 99205. Like it is 70 minutes which is in between 60 to 74 minutes. So here we have few question and answer which are very useful while coding using the time. So what is the new prolonged service code? New code 99417 will be effective January 1st, 2021. How do we use CPT 99417 when coding for prolonged services? If you exceed the total time recognized for codes 99205 or 99215, the new guidelines offer a way to receive a bit more reimbursement. CPT code 99417 has been credited to capture each 15 minutes of critical physician PHP work beyond time spent to reach the highest level of new or established patient office visit total time. So, in order to code 99417 after 99205 and 99215 is 15 minutes. So, next one, if a physician sees a new patient for 77 minutes of total time, can I bill both 99205 and 99417? No, code 99205 reflects a total time of 74 minutes. Prolonged service code service of less than 50 minutes are not to be reported. As 77 means it is in between 74 and 89. So we can't code. If it is 88 minutes also, we can't code prolonged service code. So beginning in 2021, code 99417 is used to report each 15 minutes of total time for prolonged services beyond the minimum required total time with or without direct patient contact recognized for codes 99205 and 99215, and only when billing based on time rather than MDM. So whenever we count time using the E&M code using the time, we can use this one. We will not use this 99417 while using the MDM. So here we have few examples. Total duration of new patient, officer, other outpatient services. As you know, if it is a new patient, we need to use 99205 code. So less than 75 minutes, we will not code prolonged service time. So if it is 75 to 89 minutes, 99205 into 1 and 99417 into 1. So here if it is 75 to 88 minutes, we can't code 99417. As it is 89 minutes, we can code 99417. So here, to easy to understand, add 99205, maximum timing is 74 minutes, and our time interval for 99417 is 15 minutes. So if we add 74 plus 15 minutes, it will lead to like 89 minutes. So that's why we can code 99417 into 1. If it is 88 minutes also, we can't code 99417 into 1. So if it is 88 minutes, we can keep only 99205. So if you take new patient 90 minutes to 104 minutes, we can code 99205 into 1 and 99417 into 1. Here 99417 into 2 means 30 minutes. Here 74 minutes. So 30 plus, so 74 plus 30, 104. So 105 minutes or more additional 15 minutes. 99205 into 1 and 99417 into 3 or more for each additional 15 minutes. We can code number of 99417, but we need to consider it as 15 minutes as an interval to code 99417. So here we have example for total direct time duration of established patient or office, other outpatient services used with 99215. Here as it is established patient, we need to use 99215. So here, as we discussed previously, established patient we have less timing. So here less than 15 minutes, 55 minutes, we no need to code any code. Only 99215 is enough. So 55 to 69 minutes, 99215 into 1, 99417 into 1. 70 to 84 minutes, 99215 into 1, 99417 into 2. 85 minutes or more, 99215 into 1 and 99417 into 3 or more for each additional 15 minutes. So here you need to remember only one thing. In order to code 99417, you need to have minimum 15 minutes after 74 minutes for 99205 and 54 minutes for 99215. If you find 15 minutes, you can directly add 99417 into how many frequent 15 minutes. Thanks for watching, guys. If you have any confusion, mail at fastcoder21@gmail.com. Please subscribe, like, share and comment. Happy coding, guys. I hope you understand this session. If you have any doubts, without hesitation, mail at fastcoder21@gmail.com.